Well, good afternoon, everybody. It looks like we've got about 50 people online right now, 52. So that number's climbing as I speak. And I know we've got people from as far away as Ottawa, at least. So in the chat, maybe you can just let us know if you're not in British Columbia, where you're actually calling in from today. But we do really appreciate you joining this session. And I just want to, before I get going, thank Christine and Dr. Mary Lou Harrigan for their work in pulling all this stuff together. We'll remind you of that a little later on, but great job to get us all here in this virtual context. My name's Mark Blandford. I'm the Vice President of Seniors Care and Operations at Providence Healthcare here in Vancouver. I am actually in Vancouver today. And yes, my pleasure to welcome everybody to the session. We really appreciate your support. I hope you've been to our sessions before and enjoyed them. And if this is your first time, please let us know what you think at the end. And please join us again. Lots of good information, we hope, and good dialogue. So we've got a great agenda for you today. I'm going to get going straight away. We're going to shortly welcome a couple of presenters from the Alzheimer Society of BC. Marina Hudson and Avery Milne. They are provincial coordinators of education and knowledge translation from the Alzheimer Society. And for anybody, I'm sure most people on this call would be familiar with the Alzheimer Society, but my first involvement with them goes back to, I'm going to say it was probably around 2000 when the First Link program was first created at the Alzheimer Society. And at the time, First Link was just an experiment and an innovation, and I think we on Vancouver Island were one of the first adopters. But it's now a standard protocol for early onset, early diagnosis individuals with dementia, at least here in BC. It's a standard protocol for families to be connected to First Link. And what a great job First Link does of helping to alleviate some of that early anxiety and concern with an early diagnosis of dementia. So that's just one example of one service that the Alzheimer's Society provides. They lead the way in terms of innovation. And so we're very fortunate today to have Marina and Avery join us. So enough of me, and we'll hand over to Avery and Marina, and we'll be back in about 30 minutes. Marina.
Hello. Hi there. Thank you so much for that kind introduction, Mark. So, just going to share my slides. Christine, can you make that option come up? There we go. Wonderful. Does that look okay?
Looks good, Avery.
Perfect. So thank you so much, everyone. The Alzheimer's Society of BC is really pleased to be a sponsor for this year's Dialogue on Aging series presented by Providence Health. And thank you so much for inviting us to speak to you about COVID-19 and dementia. So as Mark mentioned in his kind introduction, the Alzheimer's Society of BC is a provincial charity dedicated to helping anyone concerned with or facing dementia have the confidence and skills to maintain quality of life. So my name is Avery, and I'm here with my colleague Mariana, and we're part of the advocacy and education team at the Alzheimer's Society of BC. So we have a 25-minute session today, and here's our plan. So we will explore the importance of meaningful connections by looking at lessons learned during the pandemic and strategies for supporting ongoing connection with family members and friends. We'll share some resources to help support these meaningful connections, either through the phone, online, or in person, and ways to communicate with someone who's experiencing changes in communication due to dementia. We'll also provide you with some information on which services and programs are available to you right now during the pandemic. And then we'll finish by sharing some information about the First Link Dementia Helpline. And so part of the reason we chose this topic for our talk today is we were just reflecting and thinking that COVID-19 has been an incredibly difficult time for many people. and that many of us are feeling increased levels of stress and anxiety and uncertainty. And this is partly because the situation keeps changing. For example, the recent changes in policy here in BC. And so with so much out of our control, we're choosing to focus today on meaningful connections. In times of instability like this, our social connections can still be constant, but may look in a different way. So our talk today will draw from several great resources, and we'll make sure that these are shared with you in the follow-up email after our talk, as well as in the chat box today. So we wanted to start with a quick poll, and this is our first time doing one of these polls, so we'll see how it goes. Be patient with us. But we just wanted to know of our audience today what your relationship is with dementia. So if Christine, you'd like to put up that poll. Our question for you in the audience is, are you living with dementia, or is someone in your life living with dementia? And your options will be yes, no, or I'm not sure.
And we just want to provide a short explanation about the I'm not sure option. That really refers to a situation where maybe you recognize memory or behavior changes in either yourself or others in your life, but maybe you just don't know if it's dementia or due to something else. So something to think about as you're choosing one of the options there.
And Mariana, are you seeing the poll from your end?
Yeah, the poll's there. We'll just maybe give another 30 seconds or so for everyone to make their selection, and then we'll hopefully see the results. So we'll just give another, less than 30 seconds. Okay, we've got the results. I don't know if you can see them, Avery, but I'll read them out. 41% say yes. So they're either living with dementia or they know someone. 37 say no, and 22% I'm not sure.
Mm-hmm.
So thank you everyone for sharing that information with us. And I just want to add a couple more notes here. So even if you answered no or I'm not sure, which is the majority of you, you might find the information that we share with you today is applicable to you even if you aren't living or caring for someone with dementia. We know that approximately 70,000 British Columbians are living with dementia, and this number only captures those who have had contact with the healthcare system or a confirmed diagnosis. So we know that this number is likely an underestimate. Now, according to the Canadian Institute for Health Information, 1 in 20 Canadians over the age of 65 lives with dementia. Now, after the age of 65, the risk of developing dementia doubles approximately every 5 years, with 1 in 4 Canadians over the age of 85 living with dementia. Now, what these numbers mean is that as you get older, you or someone you know might be affected by dementia in some way. So thanks again for sharing, and we'll move on.
So you can see from these two images I'm about to show you a reflection of how things have changed over the past year. So we've gone from gathering in a room like this that you'll see on the screen where, we're sitting around a table sharing food, and, we've transitioned to connecting virtually with our friends and family. So with that said, let's talk for a minute about COVID-19 and loneliness. So organizations like the Canadian Mental Health Association have long been raising awareness about growing rates of loneliness even prior to the pandemic, especially in older adults. So the UK has even appointed a Minister for Loneliness in 2018, really recognizing it as a key concern. However, the changes necessitated by physical distancing and other prevention measures have increased people's feelings of loneliness to the point where it's sometimes described as a parallel epidemic during COVID-19. So a recent survey conducted by Ipsos found that 54% of Canadians reported feeling more lonely and isolated. This survey polled Canadian adults of all ages. And then for people living with dementia and caregivers, these feelings have been even more heightened. So the researchers, Dr. Tam, Doso, and Robillard looked at the impact of COVID on people living with dementia and their care partners, interviewing hundreds of British Columbians. So people living with dementia were often more restricted and confined within their home, some without opportunities to leave the house to get groceries, attend regular healthcare services, access community networks, or receive home support. So in their study, they found that 83% of participants reported that they felt lonelier and more isolated than they did before the pandemic. The caregivers surveyed for this study, nearly all said as well that not being able to visit a person they cared for in long-term care or palliative care due to restrictions on visitation was a major concern. So humans are naturally social creatures, meaning that loneliness can have serious impacts on our health. It raises levels of cortisol, which is the stress hormone. It can cause sleep disruptions and elevate our blood pressure. Loneliness may also make you feel anxious, irritable, or depressed. So it's really important to check in with yourself and be honest with others about how you're feeling. At the end of the day, physical distancing should not mean social isolation.
Now, one way to combat loneliness is to be socially connected, especially through connections which feel meaningful to you. There are benefits of connection for everyone, including people who are living with dementia. So we'll start by looking at some of the benefits. So staying connected socially helps you stay connected mentally. Research shows that people who regularly interact with others may maintain their brain function better than those who don't. And staying socially active and involved with life not only keeps relationships strong, but has many health benefits such as reducing stress and boosting mood. Connecting with new people in different settings helps open your mind up to new perspectives, widen your social network, and reduce depression and isolation. As well, social activity, whether that's casual interactions that you have with people or more structured like a volunteering role, can help all of us to continue to engage and feel fulfilled, ultimately improving our quality of life. Now, at this time during the pandemic, we need to be deliberate about our social connections because they're no longer built into our daily lives the way they were before. Now, in the next few slides, we'll be sharing some tips and strategies for communicating across different mediums, such as video chats, phone, and in person. These tips and activity suggestions were designed for people affected by dementia, but many of them can apply to all older adults. At the end of the presentation, as we mentioned earlier, we'll be sharing some resources with you so that you can learn more about some of these strategies and put them into practice. Now, as you are already probably aware, video calls have had risen popularity during this time. In the study that we mentioned previously, which polled people living with dementia and their caregivers, the use of technology was reported as a way to connect socially with their loved ones, with the majority of participants connecting with others at least twice a week. So let's take a look at some of the tips for making the most out of video calling. So start by setting the stage. Make it as easy as possible for the other person. If the person you're calling is unfamiliar or maybe unable to set up technology on their own, see if there's someone in their household or in their care home if they're living there who can assist them. You may need to call ahead to provide some direction on how to do this. Also, consider sitting down for a coffee and a snack and then starting a video call. That can make the conversation feel a bit more natural. Another tip to consider is just considering the best time of the day for the person that you're calling. For a person who's living with dementia, this is usually not early in the morning or during late afternoon when energy levels are typically at their lowest, but again, depends on the person in the situation. It may also help to establish a routine, calling at the same time of day. Now, you may wish to put a regular connection with people in your daily schedule to give yourself things to look forward to and encourage you to keep reaching out. And a last tip to consider for video calls is just start simple. One of the common pieces of feedback we've heard from people living with dementia is simply that their preference is to have one-on-one calls. While some people were comfortable with having multiple family members on a video call, most actually found it to be a challenge in differentiating who is speaking. This can actually lead to someone feeling lost in a call. Now, in addition to these tips, here are some activity suggestions that you can consider on your next video call. Play music. Now, we know that music touches every part of the brain and can be a particularly meaningful way of connecting with someone, whether you are in person or at a distance. Try playing a favorite song, or if you know how, playing a musical instrument can be a great way to connect too. One story that was shared with us was a woman who set up a video call with a friend of hers who lived in a care home. The woman played her guitar while playing traditional Christmas songs for her friend. Now, it lifted her friend's spirits and also the care home staff who were near the person at the time on the phone. So everyone benefited and felt connected in some way. Another thing to consider is sharing your skills. Teaching something to someone is a great way to boost self-esteem and have fun. Ask your family member to show you how to do something you know that they can still do well, such as playing the harmonica, or if they live at home and still own a car, maybe just showing someone how to properly wax a car. Whether you're living with dementia or supporting someone who is, we all have something that we can teach to someone else. You could also consider working on a project together, such as picking a recipe and cooking it together, or painting a picture, something that you can both do together through a video call while you're still talking about your day-to-day lives. And finally, consider doing activities together, like playing a game, for example. A colleague of mine told me a story of an incredible woman she knows who was diagnosed with mixed dementia. And while she had trouble navigating her way to and from the local mall in her community, she could beat anyone and everyone at crib years after her diagnosis. Think of a game that you know the person you're calling enjoys and try playing it over a video call, such as the classic charades or I Spy. There are many options online that bring interactive games and video calling together, and we will be sharing an activity resource at the very end, again in that resource document from McGill University that has some of these ideas that you can try out.
Thanks, Mariana. I wanted to talk a little bit about phone calls, which of course are a tried and true method for connecting and maybe more accessible to some than video calls. So while we're all familiar with phone calls, I just wanted to share a few tips. The first is to make it comfortable for yourself. You might wish to use headphones with an audio capability, like the ones that come with your iPhone, or put your phone on speaker to give your arm a break. I've personally really been enjoying putting my headphones in and calling someone while I'm out for a walk. I find it helps me focus on the conversation and get some exercise in too. As well, it always helps to introduce yourself over the phone. Don't assume that the person knows who you are or recognizes your voice, as it can be difficult without those added visual cues. We've heard from many people that phone calls are sometimes difficult these days. Sometimes it feels like there isn't much to talk about, as we may feel like we have less going on in our lives to update friends and family on. So we have a list of conversation starters to encourage meaningful conversation and reminiscence. Tips such as, tell me about your wedding day, or what are some of the things you're most grateful for? We also heard from someone who would read a page of her mother's favorite book to her aloud each day over the phone. So her mom would put the phone on speaker and listen to her favorite book being read to her by someone that she cares about. I thought that was a lovely idea. Another idea is you could read the news together over the phone and discuss it together. If you're finding the regular news cycle to be overwhelming, which I think is a common experience for many of us, there are good news story websites that you can look at and use, or you could look at magazine articles to talk about that align with your interests, so maybe on bird watching, for example.
Great. And many of the other tips for success that we've shared apply to in-person visits, such as finding the best time of day for a visit. Now, if you're visiting someone in a care home, inform yourself of their visitation rules so that you know what to expect. Ask about what you're allowed to bring in, such as food, for example. Another consideration is to support and don't do. Really think about the best type of activity that will promote success for the person and you. Demonstrate as you instruct and offer help only when it is needed. Be patient, slow down, and repeat instructions as needed. Remember that involving the person living with dementia in activities is not simply just a way to keep them busy. Activities provide valuable opportunities to share a meaningful moment and boost self-esteem. A last tip to talk about is to offer encouragement and gratitude. To be supportive and encouraging, say positive words and maybe avoid criticism. Thank the person or express your appreciation when the activity is over. Now, some activity suggestions for in-person visits include spending time doing something together. For example, turning on some music and dancing, or as the weather is starting to get nice in BC, which is a very welcome distraction, doing some gardening. Find projects that both of you enjoy doing, such as making a bird feeder, creating a scrapbook, or making a flower arrangement. These involve a little bit of preparation, but can be a great way to spend time together. Now, we've talked about reminiscing already, but Reminiscing is also important in person as well. This is a great way to invoke memories from a person's lifetime that might not otherwise come up in regular day-to-day conversation. So if you're looking for some new conversation starters, consider asking a question like, did your car or truck ever break down? A question like this can lead to follow-up questions like, what happened? Tell me more about it. And then perhaps lead into storytelling like, oh, I remember the first time I had to change a tire. I was 16 years old. So it can really deepen a conversation at that point. And finally, a last suggestion here is activate the senses. Now that's referring to touch, smell, sound, sight, and taste. It can be a great way for meaningful connection. Some examples include bringing food to share together. This can be especially significant if you have cultural food to share. Now, it doesn't have to just be food. It can be drinks like a smoothie or a favorite tea as well. And consider also creating a sensory box. Now, this is also known as a memory box or rummage bins. There's lots of names for this, but the idea is that these boxes or bags contain everyday objects to support interaction. Similar to the idea of reminiscing, it allows people to connect with objects that can help invoke memories and create a connection to the past. So for example, seeing and touching a whistle can remind someone of a bad memory, maybe in gym class, or perhaps invoke a good memory of maybe a time someone spent coaching the swim team, for example. And finally, we want to leave you with just a few strategies that are helpful to know when you're communicating with a person who's living with dementia. We share these with caregivers and healthcare providers. However, these are really helpful strategies that honestly work in any kind of setting and are always good to remember when speaking with others. We'll start by looking at speaking slowly and clearly. Now, a person who's living with dementia may start to experience changes in communication. So keep in mind that their brain may be processing information a little bit slower than yours. The pace of your conversation will depend on the person's ability and where they're at in the disease. Using simple words and short sentences can really help make a message clear. And if the person has hearing difficulties, you might want to consider lowering the pitch of your voice, which is often better than increasing volume. It's often actually best not to shout. Doesn't always help. Another thing to consider here is sharing one message at a time. For some, hearing too many pieces of information can actually be very overwhelming. Too many thoughts or ideas at one time can actually lead to a lot of confusion. So it's best to break down instructions or thoughts into short single sentences, and in some cases, it's even best to limit choices. Give the person time to absorb what you're saying before moving on to the next sentence or idea. And finally, show and talk. So it's using your actions or gestures to indicate more information, as well as your words. So for example, if you're living at home and you're trying to indicate to someone that it's time to go for a walk, pointing to the door or bringing a person's coat or sweater can actually illustrate what you mean. Now, this is just a very small glimpse to the many strategies and tips that we offer at the Alzheimer Society. So again, it'll be referenced in the resource document, but I encourage you to read about our communication handout to learn more.
So we've given you some tips and strategies and things that can be done. But that said, at the end of the day, one of the most meaningful things you can do is just really be present for the person you're connecting with, both for yourself and also for them. So on a call, for example, doing your best to be fully present, just trying to give your undivided attention, resisting the urge to multitask. At the end of the day, each day brings the opportunity for a new connection. So try to make it as positive and meaningful as possible.
We would just like to end, the last two slides that we'd like to show you is we'd like to share some information on our support and education programs that Mark kindly introduced at the very beginning. Our First Link Dementia Support connects people living with dementia, their caregivers, and families to support and education at any stage of the dementia journey. Because of COVID-19, of course, we're currently providing virtual services. Now, in terms of support, we currently offer support through our telesupport groups for caregivers, and we're in the process of launching our telesupport groups for people who are living with dementia. We also offer one-to-one support calls to all clients and our First Link Dementia Helpline, and our now online fitness and social program called Minds in Motion. We also refer to other healthcare and community services as needed. Now, in terms of the education side of things, FirstLink also offers opportunities to learn about the disease, including our workshops and wellness series. Now, since the onset of COVID-19, we've had to expand our webinar series, offering weekly sessions that are recorded and available online. And we also publish quarterly newsletters for people living with dementia and caregivers, as well as education e-blasts. Now, in the chat box, Avery is going to kindly share a link to a resource document that contains several links to documents that we've referenced throughout our presentation today. It also includes our contact information and key links on our website that you might find helpful. The FirstLink Dementia Helpline, which the information appears on the screen in front of you, is available throughout the province and accessible to everyone, not just people who are affected by the disease. We encourage healthcare providers, first responders, and members of the general public to call with their questions about the disease and supporting people living with it. We offer this helpline service in English, Mandarin, Cantonese, and Punjabi. Just like to give a couple examples of why people call us, why people call the Dementia Helpline. They want to learn more about the Society's programs and services, like the ones I just described to you in the previous slide. They want to learn about issues around communication and behavior, or home and community supports that are offered by the health authorities. Some people want to talk about challenges that are related to caregiver stress, or just learn about information, anything regarding dementia, really. Now, since the pandemic started, we've been receiving quite a few calls related to COVID-19, generally focused on addressing communication and behavior challenges that caregivers are experiencing in light of isolation and physical distancing directives. Now, this brings us to the end of our presentation today. Thank you for your attention and for participating. We hope that you've come away today with at least one new idea for making your connections meaningful in your day-to-day. Thank you, and we hope that you enjoy the other talks this afternoon.
Thank you.
Thank you very much, Mariana and Avery. I like the last point there, that making sure that if you do nothing else today, check out the Dementia Helpline. As I said earlier in introducing the talk, I was involved very early on in the FirstLink program, as was our next speaker, the Seniors Advocate, Isobel Mackenzie. I believe she was involved in one of the very early FirstLink programs. And now it's expanded to a fabulous service for families at all stages of dementia, but particularly at that early stage. And I think the other tip I'm taking away from you guys is to be present. One of my failures through COVID has been too much multitasking while on video. So I've taken the opportunity today to be fully present at this talk. So welcome back, everybody. We're having some issues with my webcam at my end, so you can't see my face, but just a reminder, Mark Blandford, I'm with Providence Health, and I'm just facilitating the session today. So it's my great pleasure to introduce our next speaker. Isobel Mackenzie is the Seniors Advocate for the province of British Columbia, and I'm going to keep it simple because Isobel has been my boss twice in my career, and she's pretty modest. She won't say this, but I will say this. I think that Isobel's office and Isobel as the advocate has had a profound effect on seniors care in British Columbia. She was reminding me the other, I think it's 10 years, Isobel? 10 years since the office?
7 years.
I thought it was
just
much
seems
shorter
like
than that.
10.
Yeah, it does. But the office has had a profound impact on our province in British Columbia. And for those of you outside of BC, you may not realize that the Seniors Advocate position in the province of BC is legislated. It's appointed by an ordering council. And so Isobel has a legislation, and she can explain it, I guess, but basically it's a legislative position, which isn't the case in other provinces. So we've had a number of great reports from Isobel, which have guided many of our actions to statutory health authorities. But I think the biggest testament to the impact is that way back in the early days of the Advocate's Office, nobody really understood what it was. Whereas now, every decision table I sit at in the seniors realm, everybody wants to know, well, what would the seniors advocate think of this? Where is the seniors advocate position on this issue? So it's front and center in our decision making in this province, and I think that's a testament to how Isobel's run the office and performed as the advocate. So I have other things I could say about her as a Scottish person, but we'll leave those to another day, just being an English person. But I'll leave Isobel to put me in my place. Isobel, welcome and thank you.
Thank you, Mark. And just a reminder that the best thing to come out of England was the road to Scotland. It's my pleasure to present to you virtually this year. I am accustomed, I think Mary Lou is out there somewhere. I am accustomed to talking to many of you in person at least once a year. I look forward to it, and I look forward to returning to it. The impact of COVID has been different on different people's way that they perform their job. I still come to my office every day, but what I have not been able to do for the past year is get out and about and meet with people directly in their communities. And I would normally spend about 40% of my time out of the office going around British Columbia, meeting with seniors, meeting with their families, meeting with service providers in the communities in which they live. And nothing really replaces that. Zoom technology and whatever this technology is we're using today have certainly allowed us to remain connected to some degree. And it has also opened up, I think, some new connections that we will be able to build on in a post-pandemic world. But it doesn't replace those in-person meetings, particularly around the people that will come up to you at the end of the meeting and talk about their issue, which they would not feel comfortable doing in a wider forum, such as sharing in a virtual meeting or even in a meeting in a town hall, but they'll talk one-on-one. And sometimes that's where you really find the most profound and moving stories, and you are able to dig through and reveal some rather hidden issues. So I very much look forward to getting back to that. And I think it's not going to be much before the fall of 2021, but hopefully, fingers crossed, it will be that way. And next year I can connect with you all again in person. So I'm just going to start. I generally start my presentations with giving people a reminder of what the situation for people age 65 and over is in the province of British Columbia. So as many of you will know these numbers, they don't shift dramatically year over year, but let's just take a look-see at what's happening across the province. So this year, we crossed the magical threshold, and there are now over 1 million people age 65 and over living in BC. 20% of our population. And I think the important thing to remind ourselves of is that that means 8 out of 10 people in British Columbia are under the age of 65. So before we get carried away thinking that it's all about seniors and seniors are voting everybody into office and directing everything, I think we need to take a step back and realize actually that's not the case. The majority of people, the vast majority of people, are still under the age of 65, and they are still the major drivers and influencers of policy and resource allocation in the province and the country at large, and will be actually for the foreseeable future. So we need to keep reminding ourselves that seniors do need the additional protection or advocacy, if you will, of a minority population, because they are. So 93%, over 9 out of 10 of people over the age of 65 in BC live completely independently. And that's important to remember as well, because when we look at people over 65, everybody doesn't look the same, act the same, and live the same way. There is great, great diversity amongst the million people that we call seniors in this province. And I look at the age 85 for a lot of data, and it will become more evident in the next slide. But one of the reasons I look at 85, it is when we start to see a marked difference in the use of the healthcare system. And it's also pretty close to the average age of somebody living in a nursing home in British Columbia. So when we look at 85 plus in BC, over 7 out of 10 people live independently. 72% of people 85 and over in this province still live independently. About 10% live in what we would call a retirement community or assisted living. Those lines can get blurred a bit, but in practical terms, it means they're living in a congregate setting. They have their own unit or apartment. It will often have a kitchenette or a kitchen, usually a separate bedroom, and they have common dining where they may get together for dinner or maybe all 3 meals a day and have some common activities if they wish to participate. Some people who live in these sites will receive some assistance and care. Some will receive none. They're simply there for companionship and not having to cook anymore. So that's about 10% of our population, 85 plus. 15% of people 85 plus live in what we call long-term care or nursing home or residential care. They're all captured in the same spirit of 24-hour on-site response and care provided for the people who live there. So what that means is that 85% of the people over the age of 85 in this province do not live in long-term care. And so we need to remember that, particularly now when there's a significant focus on long-term care, and there should be, and there are going to be pushes for improvements and changes in long-term care, and there need to be, but we need to remember that looking at long-term care and fixing long-term care does not in and of itself address the needs for the majority of seniors in British Columbia or indeed in Canada. So let's look at the income of seniors, and this is where there's a little bit of a oh, really moment from a lot of people. The median income, and most of you will know that means 50% are above and 50% are below. The median income of somebody 65 years of age and older in this province is just over $29,000 a year. That's just a little bit above a minimum wage job, full-time minimum wage job. And almost a third of BC seniors are on the Guaranteed Income Supplement, the GIS. And this is really, so the 28%, the almost a third that are on the Guaranteed Income Supplement, this, the reason why this is a good proxy for poverty is because GIS does factor in household income. So this is not a situation where a particular individual has a low income, but their spouse has a high income. That's not what you're seeing with people on GIS. And this group of people have an income generally less than $25,000 a year. And that is less than a full-time minimum wage job. So that's almost a third of our seniors. 27% have personal incomes under 20,000. Now this number is skewed ever so slightly by people who might in a particular year have a significantly lower income than another year. But when you put the two together, you get a pretty good idea that there's, roughly a third of our seniors who really do have some challenges around sufficiency of income. Just over 30% of people 65 to 69 are employed. This number has grown since I started doing these presentations. It was 24% when I started, and I predict it will continue to grow. We are not just living longer, we are living healthier, and the generations that are coming up have started their permanent full-time engagement with the labor force, as we call it, at a much later age than preceding generations. So time taken out of the labor force for post-secondary education, for exploring what life's all about over in Europe for a couple of years, all of those things are adding up to make it less likely that we've got our full 44 years into the CPP plan at the age of 65 than it was for preceding generations. So I think this is healthy, and I think that we will continue to see that number grow. 40% of people 65 and older volunteer, very strong contributors to our communities in a whole variety of ways. At the age of 65, 91%, over 9 out of 10 people have a driver's license. By 85, that's down to 36%, less than 4 out of 10. And yet, people are still living independently. They are volunteering. They're wanting to get out and about. They don't have unlimited incomes, but they no longer have their private vehicle. And so that is something I think we need to look at in terms of what changes we're going to make in the future. Also, the probability of living alone increases significantly as we get older. And this is particularly, I think, something we want to look at in the context of the past year with COVID and with requirements to isolate, and in the beginning of the pandemic, our stay-at-home orders. If you look here, you will see this group here. This is the group 65 under the age of 65. you know, you see a big group here, the 35 to 55-year-olds, you know, over 90, well over 90% are living with somebody else, a spouse, their adult children, a combination of both. Even the 55 to 64-year-olds, you still have well over 85% are living with somebody else. Then you start to see the probability of living alone increasing each and every year by these 5-year age cohorts. And the most dramatic jump is actually in the first jump from 65 to, from 65 to 70 in terms of living alone. So think about the impact of that in the past year, when in addition to when we look over here at the 85 plus, much more likely to live alone, much less likely to be able to drive, to get to places, to be with other people, and not having a lot of financial resources. So the impact has been more profound, I think, on community dwelling volunteers, community dwelling seniors than we might have otherwise recognized when we start to look at all those factors. I'm just going to spend just a quick time on this. What these data are telling us is the dramatic increase in the proportion of the population 65 plus relative to the proportion of the population under 65. And this is just a reminder that we have not yet seen the full impact of the what we call the boomer generation. The beginning of the boomer generation will be turning 75 this year. So the stresses that we are feeling on the system now are 10 years away from really feeling the impact that we'll feel when the boomer generation starts to come through. And you see that when you look at our segmented population and some of the health conditions. So one of the classics is when we look at dementia. So obviously, if you're under 65, the prevalence of dementia is so small, it doesn't even register to 1 decimal point. It's possible, but it's not probable when you're under 65. When you look at the entire population, 65 plus, it's 6% of the population 65 plus is diagnosed with dementia. But look what happens when you break that down between the 65 to 84-year-olds and the 85 plus. In fact, only 3% of the population 65 to 85 is diagnosed with dementia. It's when you get 85 plus, it's 20%. And remember, the boomer generation is 10 years away from being 85. Now, I think it's also important to recognize that it's only 20%. So 8 out of 10 people over the age of 85 do not have a diagnosis of dementia. And that's important when we think about our planning and when we think about where we want to live as individuals and where we want to plan for people to live as they age. And then as you can see in these data as well, it just reinforces when you look at the 65 to 85 group and the 85 plus, most of these numbers change by a quantum of double when you get to 85. And what that shift is telling us is that it's really at age 85 plus when you start to see these very marked differences in terms of utilization of the care system and in terms of care needs. So what are the challenges that have been identified during the pandemic? Well, certainly there have been a number of challenges that have been identified to the public at large. I would say that for those of us who've worked in the field, they weren't revealed by COVID. We knew they were there, but I think they've been certainly amplified by COVID, and then they have been revealed to the public at large. So we know within our care home staffing, both the sufficiency of the staffing and also what I would call the precariousness of the staffing. So having physically enough boots on the ground, as we say, is only part of the issue of appropriate staffing and long-term care. Making sure the staff are consistent, which is what's necessary for not just building relationships relationships with residents, but also familiarity with facilities and familiarity with infection prevention and control practices in each facility are also key to providing good and safe care. And we certainly found challenges around both of those in terms of the staffing during this pandemic. The marginalization of familial relationships, without a doubt, we have when we are through this, on the other side of it, all of us in healthcare are going to have to do some agonizing reflection on the value or lack of value we put on the familial relationship, particularly as it comes to the quality of life and the health and well-being of people who live in residential care. To say that we recognize how important families are is inconsistent with how we have treated families of people living in residential care for this past year. And I think many of us will have the generosity of heart to recognize that we were seized by a pandemic. We were in uncharted territory. We were responding to changing dynamics almost daily. And many things we predicted or thought might have happened didn't exactly unfold the way we thought or predicted they might happen. And all of that, I think, can be used as a rationalization for why we had to do, or not had to, but why we did what we did the way we did. But we have to have the capacity and the humility to reflect on the fact that our actions did not support a philosophy of the importance of familial relationships. And that's in residential care and acute care. And it is about the healthcare system writ large. We also saw identified in care homes the issues of public care homes versus contracted care homes. You know, this what rights does the public have to dictate to private operators what they can and can't do when they've got publicly funded residents? I think there's going to be a lot of discussion about that. I think the value of the quality of life versus sustaining life has to be examined in the context of long-term care. So yes, we kept people safe, but for what purpose? So if we look at the deaths in long-term care versus the deaths from all the other things in long-term care, many of which are preventable, I think, again, in my, going on 25 years now in seniors care, I've never seen immortality as a goal of care on any care plan I've ever seen. So we've got to really understand what that means, and that segues into rights versus risk. It's challenging in a congregate setting around an individual's right to put themselves at risk and how that might put others at risk, and where is that line? But certainly a number of issues in care homes were identified during the pandemic. There were also a number of issues identified in the community. So the issue of living alone, which in and of itself is not necessarily an indication of loneliness. A person can live alone and not be lonely. A person can live with a number of people and feel lonely. But living alone is a risk factor for a number of things. And that was amplified during the pandemic as suddenly there was nowhere for seniors to go, certainly for the first 4 months of the pandemic, where they could socialize with other people. Our recreation centers were closed, our libraries were closed, our senior centers were closed, our municipal town halls were closed, everything was closed. Costco apparently wasn't closed, you could still go there, but we were certainly giving a message out, and I was part of that message while we were trying to figure out what was going on, of encouraging older people to stay at home. And the living alone made that those stay-at-home orders, for want of a better term, look different. Certainly for the older adults, people over 80. Not driving. Well, now we're in a situation where sharing a taxi cab, getting on a bus, having a volunteer drive you, having another family member drive you, having another person in the car became a risk factor. Didn't have an impact on me. I can drive alone in my vehicle. But if I couldn't drive, it has put an additional strain on me that would not normally be there but for COVID, because I could get a volunteer to drive me. I wouldn't hesitate to have another person in the car. Low tech. We talk a lot about the fastest growing group of Facebook users is people over 65, and you hear all these. But the reality is, when you actually look statistically at the numbers, the participation rate in technology is much lower in the people over 65 than under, and it is lower still in people over 80 than people 65 to 80. And so that became a real issue as we depended more and more and more on technology during the pandemic. And low income. Low income became more of an issue. Now, seniors were not impacted on their income by COVID to the extent that younger people who may have lost their job were, but the expenses they incurred increased as a result of COVID. So whether it was having to pay for grocery delivery, having to pay for a taxi cab versus a friend who would normally drive them but didn't during the COVID restrictions, certainly this became an issue. And it also ties into low tech, because the number of seniors, while they can navigate the email and some of the internet, they can't afford the Wi-Fi, and they would go normally to their library or their senior center to use the Wi-Fi. Those places were closed during COVID, and so they were cut off even more. And it highlighted the importance of the libraries, the senior centers, and the rec centers. And these were all some of the latest places to reopen and have not completely. Libraries didn't. I can't figure out why we took so long to open our public libraries, but we did. They were not open until the fall. And so that was a fairly long period of time that seniors went without the support from the library, which we may have underestimated. The other challenge during the pandemic was finding bandwidth to deal with anything that wasn't COVID related. So we've got an abuse and neglect report we want to get out. We've got an incomes report related to costs of healthcare we want to get out. We've got a variety of things. And the reality is nobody has any bandwidth right now to listen to anything that isn't about COVID. We thought we were maybe gaining some bandwidth, and then the third wave came along. And when it comes to seniors, the focus is all on long-term care at the moment. And we need to be very, very careful of that, because while long-term care does need more attention, without a doubt, it is not where the vast majority of seniors live or ever will live. And we need to remember that. We need to remember that community supports are necessary as well. So let's talk a little bit about COVID in long-term care in BC. We have this data. These data are correct, I believe, as of the end of March. And as you know, there has not been dramatic activity related to COVID in long-term care, thankfully, over the last few weeks. So in British Columbia, there are 521 long-term care and assisted living sites that were covered by the public health order because they are either under the Community Care Assisted Living Act or the Hospital Act. So these numbers do not include what we would call independent living sites, which were never captured by any particular public health order. There's no regulation. There's no way to accurately know how many are out there. So there's 309 of these sites are long-term care, and 212 of them are assisted living sites. Most of the long-term care sites are a combination of either exclusively publicly funded beds or some privately funded and mostly publicly funded beds. And there's a handful of sites that are exclusively private pay long-term care beds. Most of the assisted living sites are a combination of private pay and publicly funded. There are very few completely publicly funded assisted living sites in the province. Almost all of them are run by contracted providers versus long-term care, where a third of them are operated by health authorities. So that's a bit of context. 309 sites had no outbreaks. So just the majority of sites did not experience an outbreak during COVID. Of the 212 sites that experienced one or more outbreaks, they experienced a total of 358 outbreaks. So, and I don't need to tell Providence, as you know, some sites experienced multiple outbreaks. Overall, 51% of our long-term care sites experienced an outbreak. 77% of long-term care sites in the Lower Mainland experienced an outbreak. So there's a clear linear relationship, as we would call it, between the level of COVID transmission in a community and outbreaks. You can see that when you look at the map. But even that didn't look the same between long-term care and AL. Only 17% of assisted living sites experienced an outbreak, although again, the bulk was in the Lower Mainland. 56%, over half, just over half of the outbreaks were contained to one staff person. They did not infect a single resident. 69% of the outbreaks involved less than 4 people. And 75%, 3/4 of our outbreaks, resulted in no deaths in long-term care. So this is where our review really has the most questions to ask. Whether or not you experienced an outbreak, we predict is going to, for the most part, be linked to the likelihood increased if your community spread was higher. We know that from initial numbers already. We may find some other difference, but we're not expecting to. The real question we want to understand the answer to is, why did some facilities experience prolific outbreaks, large outbreaks, while others experienced very contained outbreaks, given that these outbreaks would happen relatively at the same time in the same community? So the community spread and other factors were the same. What were the differences that led to an out of control outbreak and a contained outbreak? And we're just in the beginning stages of analyzing why that might be. And we're hoping to be able to provide some answers to those questions at the beginning of the summer. There were a total of 4,200 cases in the 358 outbreaks, 2,615 residents and 1,667 staff cases. There were a total of 778 deaths, which is 53% of all the COVID deaths in the province. So you will notice that this is lower than other numbers that we've heard. I would caution, British Columbia's second wave looked very different from our first wave. Ontario and Quebec had extremely horrific first waves. We did not. Their second wave, in the case of Quebec, was actually better than ours, and in the case of Ontario was about the same as ours. But the impact of that first wave, particularly around long-term care and long-term care infections and long-term care deaths, drove data because of the numbers in terms of a large Canadian average. So, and I also know that this number will go up a little bit when we start to sort out those residents who were transferred to hospital and died in hospital would have their location of death recorded as hospital initially, and it's going to take there's a lag until we can tag that back to long-term care. But what this picture tells us is we've had, I think something in the neighborhood now of 110, 120,000 cases of COVID in the province, 4,200 in long-term care, or 2,600 residents in long-term care. And that is less than 10% of our residents in long-term care contracted COVID. And 778 people in long-term care died from COVID. By the time we're through this, that number, for sake of argument, is 800. Remember that in a given year, about 8,000 people die in long-term care of things obviously other than COVID. We're looking at whether, in fact, there is excess death in long-term care. There was an article in the Globe which came up with a different number than we did. We're not seeing what we would call a statistically significant difference in deaths in long-term care over the period of the pandemic, in part because some of the measures we took to keep COVID out may have reduced deaths from influenza. There may have simply been a substitution effect. But remember that while these 800 people have died from COVID tragically, think about the approximately 8,000 people that died of something other than COVID and how they spent the last year of their life in long-term care. Because the couple of things I want to talk about now. So as many of you may know, we did a very extensive survey in September of family members of residents in long-term care about the impact of the visit restrictions. When people were answering this question, they had been allowed to visit under the revised one designated social visitor policy for 2 months by the time they answered this. And their loved ones had been under visit restrictions at this point in time for 5 months, 5 to 6 months by the time they answered this. Now, there was another 7 months after they answered this survey of people still living under the kinds of restrictions that were in place when people answered this survey. So when we look at it, we asked people, what was your frequency of visiting before, and what is your frequency of visiting now? So before the pandemic, you can see that the majority of people, 59%, visited several times a week or daily, right? So this is a very involved family member whose relationship with the person in long-term care is very strong and undoubtedly links to that resident's quality of life and to the level of care they are receiving. For a year, the majority of people were visiting only once a week or less. Gone were the several times a week or daily visits. Then we asked people about the duration of their visit. So before the pandemic, what we see here is that the vast majority of people are visiting for more than an hour, and that about just over around a third would be visiting for an hour or less. What they've experienced for the last year, half of them were getting 30 minutes once a week. Some were getting an hour once a week, an hour or up to an hour, right? So think about that shift for that resident. Think about the spouse that used to come and visit daily, now can only come once a week for 30 minutes in a common area, wearing a mask, 6 feet apart. That's what they got for in fact, they didn't even get that for a year. For 3 to 4 months, they got nobody. And then for the following 8 or 9 months, they got once a week for 30 minutes in a common area, 6 feet apart with the mask on. Some even had plexiglass. So clearly this had an effect, and we see this. This is the prescribing for antipsychotics in long-term care. This here is when the pandemic started, okay? This here is the preceding 3 years. So you can see we bounce around a little bit, right? And these are 3-month increments, right? Or 2-month increments, I think. Yeah, 2-month increments. So we bounce around a little bit. You can see that, right? And then look, pandemic hits, up, 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 up. Oh, we thought we were getting better, up, up. And this, when we took this measure, this graph demonstrates, I think, an 8% increase. It's now a 10% increase. It's continued to go up. In my time of measuring these data, I have never seen a decrease of 10% in a single year, or more precisely 10-month period, either up or down. We have wiped out all the gains of our campaign to reduce antipsychotic use in long-term care, which, by the way, was successful. And we are going to be monitoring this and hoping that if it went up this dramatically, it could go down this dramatically. So we're hoping to see that when life returns more to normal in long-term care. It's not back to normal yet. Part of this will be a reflection of the visit restrictions, but not all of it will be a reflection of the visit restrictions. Some of this will be a reflection of people forced to isolate for 14 days when they were first admitted. Some of this will be a reflection of the strains on the staffing, which have made less time available for some of the non-pharmacological interventions to de-escalate agitation and aggressive behaviors. There'll be a variety of reasons. It won't just be the visit restrictions. So it's not going to look the way we want to see it look for probably possibly another year, but then we should be starting to see that downward trajectory. So this is a real impact that our residents have experienced. So post-pandemic changes, we need to assess what we learned. We need to put our experience into perspective, and we need time in order to do that. I don't think we're at a place yet where we can put this whole experience into perspective. We need to remember that most seniors want to and do live at home in the community. We need to understand the impact a person's income has on the choices that are available to them. The income in and of itself no longer buys better health by the time you're 85, but it does buy you different choices if your health starts to decline. We need to focus on the quality of life balanced against risk, and we need to recognize that immortality is not a goal of care. And without a doubt, we need to re-examine the attitudes of healthcare towards family members of patients and residents. So you'll all be relieved to know that that's the last slide. So I'm not sure what I do to stop the slideshow and return to the screen. I'll let you guide me on that, Christine.
Thanks, Isobel. And thanks for working with the frustrations of the technology there. Yeah, we'll probably figure that out afterwards, but I think we got some pretty interesting stuff there. I like the last slide, talking about the fact that we're probably not there in terms of an ability to reflect back, but I know many of us in positions like mine are reflecting on what we did in the past 12 months, and not all of it was the way we would like it to have been done. Yeah, I like that the last but one slide around the increase in antipsychotic medications. I hadn't seen that. I had a sense that data was high. That's a salutary piece of information that we have been using those medications in lieu of other things. So yeah.
And that data is right out of PharmaCare, Mark. So it's arguably more reliable than the inter-eye data. But even when we looked at Q2 of the inter-eye data, because of course the problem with the PharmaCare data is that it only captures the CCALA sites. It doesn't capture Hospitalac sites. But traditionally, we've not seen much of a difference between sites based on their regulatory regime or licensing regime. And we didn't see the difference when we looked at Q2 of the inter-eye. So we have definitely been significantly accelerating our use of antipsychotics.
Yeah, that's a pretty salutary piece of information. I know we've got time for questions. Christine, do we have any questions coming in? I've got a couple I can roll with here, but do we have any questions?
We've got quite a few, and yeah. I'm just going to check. We've got at least one hand up to ask a question. So Barb, if you have a question for Isobel, I can unmute you here. Actually, you're unmuted. And while Barb's working on that, we do have, we have a number of questions here about creative solutions, but we have one speaking to the antipsychotic medication, and really wondering if there's something that families can do in the event that there is an encouragement for antipsychotics.
Well, remember your rights. I think Krista is, following me in these presentations, and she will certainly highlight to you the work that she's been doing around medication authorization. I mean, at the end of the day, you have to give consent to medication, and if you have a substitute decision maker, they have to give consent to medication. What we sometimes are not recognizing is the blanket consent we've given. And we may be, and I think during COVID, there would be, I think, as I say, some capacity for understanding this, that family members may feel overwhelmed in terms of being able to present alternative theories for behavior and alternative solutions to the behavior rather than the pharmacological solution. And don't forget, the families have not been in there. So how much of the increased use of antipsychotics is because the behaviors have triggered because of the lack of family contact, and how much of it is because the families haven't been in there on site to advocate for their loved one in terms of not getting the antipsychotics or observed the deleterious effect and started to ask some questions. I think, that's all part of it. So know your rights and exercise your rights.
Thanks, Isobel. I'm going to go to Donna. Donna, you just need to unmute yourselves. There you go.
Isobel, can you hear me? Yes?
I can, yes.
A long time ago, I heard research, and I've yet to see even working it. And that is a controlled experiment with people with established routines, talking about their established routines, and then the autonomous ones where they actually had input into what went on in their institutions, the times they ate, whether they ate at a certain time, whether they had their exercise at a certain time. And they did pre-test and post-test. And the post showed conclusively that the quality of life was vastly superior when there was autonomy? Is there any research that we can start substantiating? Because as we age, what we're terrified of is being warehoused in a daycare center. And even the expensive, and I don't want to mention them, but they're very expensive places. They're the same, they're warehouses. So how do we get quality into our, I don't even want to call them long-term, because we got to find even new names to it. I've just finished doing a bit of a workshop on ageism, and there's so much research that says that our brain can continue to develop as long as we're given enriched experiences. So I know I've said a lot, but I really am passionate about this.
So we certainly, those messages are reinforced both in research and frankly in common sense. So when we did our survey of long-term care and we heard from 10,000 residents and 10,000 family members, the biggest complaint about food was they couldn't eat when they wanted. It wasn't actually about I don't get what I want or the soup is cold. That was there, but the single largest complaint, I can't get to eat when I want. I can't get. I'm not allowed to get up when I want. The autonomy question, weaving through it. Now here's the challenge. It's congregate living. So everyone wants to go to heaven. No one wants to die. We want. There is a reality to congregate living we have to recognize, because what happens is care homes will say, you can have breakfast when you want because we have a buffet with muffin and coffee for people who don't want to get up and go to breakfast. Sounds great. That is not the reality of how life runs in a long-term care home. We have staff that come on at 0700. They have to get people up, dressed to the breakfast. There is a rhythm to it. So we have to recognize what degree of autonomy can be accommodated in long-term care and what degree can't. And I think we have to do a better job of sorting out who's going to enjoy the conformity of routine, and some people do, and who's not going to enjoy the conformity of routine. And in that other group, we either find better ways to support them in their own home, or we put all the nonconformists together. Because if you are somebody who got up every morning, the totally regulated person, you're not going to find it difficult in long-term care from that perspective. You're accustomed to getting up, being dressed, and being at the breakfast table at 7 a.m. every morning. You're going to get along like a house on fire in long-term care, because that's exactly what we do. If you're I like to have tea and toast and stay in my pajamas until 10, you're going to have a difficult time in long-term care. So what we do here is we take people of every different background, every different expectation, every different routine, and we throw them all together. So when we talk about how do you reform life in long-term care, half of the equation, I think, is about having the right staff, having the right resources, and all of that. That in and of itself, however, is not going to fix the other issue, which is how do you have these disparate people that we think should all get along? One of the things that was clear from the long-term care survey, and it was a very robust survey, without exception, in every single care home, there were a group of people who were very happy and thought it was great, and a group of people who were miserable and thought it was awful. Same staff, same food, same physical environment, same routine, different outcome, different expectations, different people. And that's what we have to recognize. And we're going to have to either accept that for some people, it's not going to work, but it's the only solution. But before we do that, are we sure it's the only solution? And recognize also that for some people it does work.
And on that note, I'm going to have to close our questions and discussion. I will give Donna some hope that those of us in long-term care are having this very discussion that Isabel's pointing to right now. We don't believe that warehousing is the answer. And I think there are many of us passionate about changing the way long-term care is delivered, supported, so that people can be having their own choices. We're a long way from where we need to be, but if there's one good thing about COVID, it's shone a spotlight on long-term care, and it's given us an opportunity to influence the political arm to help us change it. And Isabel's a very strong voice in that respect. So I've taken a minute more of the time than we didn't have. So I don't want to have the last word. I just want to thank Isabel very much for soldiering on with the technology. I think the message that she has is going to get stronger in the coming months. I personally am looking forward to that. And we do want to have that difficult discussion that we need to have. So Isabel, thanks very much. I don't know if you're going to stay for the next talk. As you say, it's going to be pretty interesting. We've got Krista waiting. We're going to take a 2-minute break, everybody. Give you a chance to go to the washroom, to come back for a really interesting conversation with Krista. And we'll be back in 2. Thanks, Isabel.
Okay, and good luck with the technology. Might have been on my end, so sorry about that. Wish it could have been better, but thanks very much, everybody. I'm going to sign off now.
Advocate for that. We'll own it.
All right. Okay. Cheers, everybody. Bye-bye.
So what I want to do today is talk about healthcare decision-making rights and responsibilities, and I will address some of the issues related to the rights-based questions that came up earlier during Isabel's talk. I'm going to talk about laws that apply to healthcare treatment when it happens in home, in hospital, and long-term care. And because these are rules that have not been overridden by the pandemic provincial health orders. However, as we've all lived, the provincial health orders have definitely changed things, and they will require some creativity, I think, from all of us in how to make sure the laws are respected. So what I'm going to talk about today, I'm going to briefly outline the basics of healthcare consent law. I'm going to summarize some of your healthcare decision-making rights as a person who's receiving care. On the other end, I'm going to explain some of the legal duties that people who make decisions for other people about healthcare have, and we call these substitute decision makers. And I'm going to go through some special rules that apply when antipsychotics are given to people in long-term care. So I'll get to some of that question that Isobel had and just expand on some of what she said. My button is just visible there. There we go. So just a few words about myself. My pronouns are she and her. I'm largely of settler heritage, and I'm speaking to you from the unceded territory of the Squamish, Musqueam, Tsleil-Waututh people, of course, as an uninvited guest on their land. I'm a lawyer by training, and my work is more looking at system change, and nothing I do looks anything like what you see lawyers do on television. I've been with the Canadian Centre for Elder Law for 15 years now. So just briefly on the next slide, a few things about the Canadian Centre for Elder Law. We are part of a non-profit agency called the British Columbia Law Institute, which is BC's law reform agency. So the organization responsible for thinking about how to improve laws in British Columbia. The BC Law Institute is a non-profit agency, and we're completely independent of government at the Canadian Centre for Elder Law, although we do sometimes get funding from different branches of government to do different kinds of work. You can see from the slide here that pieces of our work, we do the law reform, we do a lot of consultation with people to find out what's going on, how we can improve laws. We do a lot of research, and we produce educational tools to help people understand their rights and responsibilities under the law. And I'm going to mention a few tools that we developed with the Alzheimer Society of BC related to healthcare consent toward the end of this presentation. So who provides consent, and how does consent happen? On this slide, I'm highlighting 4 key aspects of the law in relation to healthcare consent, and this is healthcare happening anywhere. So there's no treatment without consent. That's the first piece, unless there is an emergency. And so an emergency means that a doctor, a physician wants to provide care to save someone's life, prevent serious physical or mental harm, or alleviate severe pain. So that's emergency treatment, or someone can't speak for themselves. In those extreme cases, a physician can do something. They just like what we see on Grey's Anatomy, right? Someone's unconscious, we don't deny them care because they're unconscious. In emergency, there's some treatment that can happen. But outside of those emergency situations, treatment without consent from the right person under the right circumstances is a battery. In fact, the fact that we have a health emergency right now due to the pandemic is not the same thing as emergency, right? Emergency is specific situation in relation to your own well-being. So the second thing I want to say about healthcare treatment in BC is there a presumption of capacity. And so what that means is healthcare providers, anybody providing care, we assume that people have the ability to make their own decisions regardless of disability or age. And this means that in most instances, a person can make their own healthcare treatment decisions. Now, there are exceptions, right? But if somebody doesn't have a guardian appointed to take care of them and make their own decisions, each time healthcare is needed, the nurse or the physician is checking with that person to see what kind of healthcare they want. If a person does not have capacity to make their own decision, and that means they don't understand the information relevant to the particular health question at issue. They can't understand, they don't understand what is wrong with them. They can't understand the risks, or the benefits of the care. If they don't have capacity, then someone will provide substitute consent for them, because healthcare providers can't provide treatment without consent from someone. So my third point here, substitute consent needs to be from the right person. The healthcare provider has to get the consent from the correct person. So that could be a guardian if the court has appointed a guardian. It could be a representative if you don't have ability to make your own decisions and you've chosen a representative through a representation agreement. And if those two things hasn't happened, the healthcare provider is choosing someone, a next of kin, who's available to make healthcare decisions for you. And when they make this decision, who they choose is based on a descending list of family members that's provided in our healthcare legislation. So they're considering, do you have a spouse that is present to make decisions? If not, do you have adult children? They kind of go down the list. The list includes close friends. So if you don't have immediate family, you could still have a friend to make decisions for you, possibly, when you can't make decisions for yourself. And if there's nobody else, the public guardian and trustee is going to figure out who's going to make healthcare decisions for you. Now, finally, healthcare consent decisions must be informed. And what that means in practice is that physicians or nurses or whoever else is involved in the care situation, they need to answer enough questions for you to make an informed decision about whether you want this medication, to undergo this surgery, to go to this facility. They're supporting you to make an informed decision. And so while I'm saying consent over and over and over again, of course, there is a right to decline treatment. So the right to consent is also the right to say no. It's a right to change your mind and withdraw treatment if you decided you didn't want that treatment after all. Now, I want to highlight 4 specific healthcare decision-making rights and responsibilities in addition to this general thing about what healthcare law says. So because I think these rights are not really well understood by folks working in healthcare and just by everyone. So the first one is when we're receiving care, we have a right to accommodation of our communication needs. So these are the communication needs specific to you. And this doesn't mean just can you speak English and do you need an interpreter, but it means that healthcare providers are legally required to communicate with you in a manner appropriate to your skills and abilities. So, for example, the first presenters today from the Alzheimer Society were talking about dementia, and they made a lot of good points about communication with dementia. And so, similarly, people who are providing healthcare to someone living with dementia need to consider what are the communication abilities and needs of that person living with dementia. As Mariana said, speak slowly and clearly, right? And make sure the room is quiet so they can hear you. There are a lot of things that healthcare providers can do to facilitate communication with people living with dementia. But generally, on top of that, our human rights law says that people with disabilities have a right to accommodation of their communication needs in any kind of healthcare context. So we know that the Charter of Rights and Freedoms applies to healthcare. We know that human rights law applies to healthcare. And people with disabilities have human rights to accommodation of their unique needs and abilities. And so what this means in practice is that healthcare providers really need to get to know that person they're providing care to and try to understand how to communicate with them in a way that's going to work well for them. Now, moving on to the second slide, and this slide ties in with the exclusion of family members that Isobel was speaking to in her talk. So when we're receiving healthcare, we have a right to supported communication and decision making. And so what that means is if a healthcare decision needs to be made, maybe you need help from someone in your family to understand the question or to figure out what to do. Healthcare staff need to invite sort of those supportive, non-abusive family members into the conversation about your care needs. This right to have these people involved in the conversation is right there in our healthcare consent legislation. And this law has not been kind of eradicated by provincial health orders. It does mean that family members can't always be there in person at every moment of the day. We need to be creative about how we include family members in conversations about healthcare needs. So third, I want to say something about the responsibilities of people who are making decisions for someone else. So you might be a representative, or you might be a guardian, or you might be just making a healthcare decision for one of your family members because they can't make decisions for themselves right now. Even though they can't make decisions on their own independently for them, and so someone else is making decisions for them, these people still have some rights, and importantly, they have a right to be included in decision making. Now, whether the person who's making decisions for someone else is called a guardian or a representative or a temporary substitute decision maker, there are slightly different responsibilities, but at bare minimum, there is a right to sort of check in with that person you're making decisions for and involve them as much as they can be involved. And depending on their disability, their health issue, they might have different abilities to be involved, right? If they're unconscious, they cannot be involved in healthcare decision making. But if they have, mild dementia, they probably can then be very involved, if not making their own decisions. Once dementia progresses somewhat, they may not be able to make their own decisions, but they might still be able to say, they don't feel good when they're on this kind of medication, or they'd rather receive care in the facility that they're comfortable with rather than going to hospital. So they can still maybe participate in some ways, even if they can't direct their own care. Now, the third thing that I want to highlight is that people who are living in long-term care can still sometimes make some of their or all of their own healthcare treatment decisions. So some people can decide to admit themselves to long-term care as well because they are able to understand the issues involved in that choice. But sometimes the decision to admit to long-term care is made by family members when people's health issue could be dementia, but it could be something else. It's too progressed for them to really understand what's going on and the risk involved in living at home. In that case, there might have been a capacity assessment, and someone else, like a spouse or an adult child, might have made the decision to admit them to long-term care. But that person still might be able to decide about medication. They might be able to say that the antidepressant makes them too sleepy and they don't like it. They can still talk about their experience on medication, or they might even be able to direct all their own healthcare. The decision about whether a person has what we call capacity to admit themselves to long-term care is a different question from capacity to make decisions about healthcare. You'll remember a moment ago that I talked about the presumption of capacity. So even when people are in long-term care, we still presume they have capacity to make their own healthcare choices unless it looks like they can't. So the healthcare provider, the nurse, the physician always have to turn their mind to what is this unique person's ability to participate in healthcare treatment decisions and make an assessment based on what's really going on in their lives. We don't assume that people can't make decisions just because they have a disability. And so finally, I want to talk about antipsychotics because I know that came up earlier, and I think that's an issue we've been thinking about a lot in terms of long-term care use, because as Isobel has pointed out from her research, use of antipsychotics has gone up during the pandemic in terms of long-term care. We don't know about home and community care or acute care, but in long-term care, it seems like it's gone up. And that's not a good thing because there are health consequences, there are risks associated with these medications. So I want to say 4 things about the law in terms of use of antipsychotics in long-term care. First, if there are special rules that apply. So the law about healthcare consent that I just talked about does apply to antipsychotics in long-term care, but there are extra rules that apply when antipsychotics are administered in long-term care on top of our healthcare consent law. So, and that depends on how the antipsychotics are being used. So the question is always, is the antipsychotic being used to restrain the resident? And if we're talking about, Isobel mentioned aggressive behavior, challenging behaviors, and we're trying to control the resident for their safety or the safety of others, that medication is probably being used as a kind of chemical restraint, like a physical restraint, but a medical alternative to, like using medication to control people. Sometimes antipsychotics are actually used to improve quality of life for people, even in long-term care, right? Like maybe they have psychiatric issues, there's some kind of suffering, or they're experiencing pain. Maybe the antipsychotic is helping with that. So antipsychotics aren't just always being used for restraint, but when they are, these extra rules apply. So in terms of these extra rules, antipsychotics cannot be applied without consent unless there is an emergency. There are special rules that allow physicians to administer antipsychotics if there are serious risks and there's an emergency. But that emergency, point 3, only lasts for 24 hours. After 24 hours, if you're the family member making healthcare decisions for someone, you should get a call about whether you would agree to continued use of this antipsychotic. And you have to give agreement in writing. The rules for consent to antipsychotics for chemical restraint in long-term care say agreement has to be in writing. Other medication, it doesn't have to be in writing, but for antipsychotics that are restraining, the agreement should be in writing. And then on top of that, there are a whole bunch of extra rules about how restraints should be used in a way to minimize their use. So I won't go into all of them in detail. If you go to our blog post, we have a blog post on our website with all the details, but basics are basically, you can't use restraints to punish folks for behavior. It can't be used just for convenience of staff. And restraints need to be as minimal as possible, and they need to be necessary to prevent harm. They can't be just for convenience. So there are a lot of rules about using restraints so they're not causing harm to people in long-term care. So that, I promise you, that's the hard stuff of the law that I'm going to be covering in my talk today. To wrap up, I just want to remind people that there's a world of difference between folks who can do completely independent decision making and folks who need a guardian to make decisions for them. And between them, there are some rights I talked about earlier, right? Like maybe somebody can't make decisions by themselves, but they can make decisions if they have assistance with communication. We need to explore that first before we take rights away and go to a guardian. And then further, maybe if they have support with decision making from someone they trust, they can make decisions by themselves with that support without a guardian. So there are these steps between going to a guardian if someone has difficulty making decisions for themselves. As I mentioned earlier, we've developed some tools to help folks understand healthcare consent law because it can be complicated, and I don't expect you to write everything down I talked about today. So I'll send you to our website. There are links in my slide, and I'm happy to send these slides over to Christine so she can share them with you. This booklet on your legal rights is a plain language booklet available in English, French, Chinese, and Punjabi. You can find it on our website. And then on top of that, we've developed 3 animated videos to help people understand healthcare consent law, one on who makes decisions for you, one on getting support, and one on what to do to protect your rights if you feel like your rights aren't being respected. You can watch all those on our website. They're each about 3 minutes long. Before I go, I just want to thank our funders. The Vancouver Foundation, the Law Foundation of BC, and the Notary Foundation paid for those tools that we developed with the Alzheimer Society of BC. And also say, if you have questions, we don't get them today, here's my email on the slide. Feel free to email me. You can also find my email address really easily on our website. The URL is on this slide. We have a newsletter. There's lots of ways to stay in touch. And contact me after if you didn't have time for your question. But now I'm going to be quiet and allow you to ask a question or two.
Thanks very much indeed, Krista. I've used your website personally many times because I think those of us in healthcare, in our attempt sometimes to overprotect people and be over risk averse, we tend to take actions which are contrary to their rights. And it's one thing that I'm often reminding our staff and leaders that just because a resident's in our care doesn't mean they've sold away their rights. So I think you've explained, or you've given us a hint at least, that the nuances are what we need to pay attention to. So I'm very grateful for the reminder. And the links will also go out in the package. Now, Christine, I know we want to leave time for Mary Lou to announce the next session. Do we have time for any questions, or should we skip to that announcement?
Shall we take time for at least one question? There are lots here.
Yeah, go ahead.
So we have a question for Krista about fluctuating capacity associated with dementia, and specifically noting that changes were made to the Mental Capacity Act in 2005 in the UK. Is there something that you can offer us in terms of Canadian context?
Sure. So the presumption of capacity always applies. So, you know, if a person has capacity that changes throughout the day or throughout a month, they always kind of have a fresh chance. You know, unless a guardian has been appointed, they have a fresh chance to show capacity every time a treatment decision needs to be made. So the physician should always be considering their capacity in the here and now, and also adapting care and decisions around their needs. So if you know, for example, that you make healthcare decisions for or you help your mom with healthcare decisions, and you know she has more capacity in the morning, you can book appointments in the morning or at times of day where you know she has the best ability to participate in decision making. But the UK law doesn't apply to us, but we have pretty good laws in BC in terms of capacity rights. It's just about understanding rights, and enforcing them can be a challenge. The law itself is fairly robust, I would say.
Thanks, Krista. I'm guessing we've got 1 minute left, Christine. We should skip to the announcement for the next schedule. And once again, just to thank Christine and Mary Lou for the great organization of bringing us here today. Thanks to our speakers, Krista, Isobel, Avery, and Mariana. Very diverse session, and it would be great to just step off the stage now and have a cup of tea with people like Krista to talk about that information we just received. So let's look forward to doing that in person sometime next year. But for now, Christine, back to you, and I'll be signing off.
One of our very popular speakers, Dr. Davidicus Wong, is confirmed for our session on May the 13th at 1 p.m. So we've got some information there on the screen, and hopefully you will make a note of that date. And we will look forward to seeing you in May.